Diagnosis of sessile serrated adenomas/polyps with image-enhanced endoscopy, a systematic review and meta-analysis. Introduction. Colorectal cancer, CRC, remains one of the leading causes of cancer-related mortality worldwide. While colonoscopy decreases the risk of colorectal cancer, it is an imperfect tool with adenoma miss rates ranging from 15% to 27%. More worrisome is that interval cancers can occur within 6 months to 60 months after a normal colonoscopy, with reported incidences of up to 10.5%. Observational studies show that the protective effect of colonoscopy for colorectal cancer is markedly less for the right colon than the left colon. Sessile serrated adenomas or polyps, SSA/Ps, are often flat, subtle in appearance, and most common on the right side of the colon. Because of the difficulty in detecting, diagnosing, and delineating their borders, SSA/Ps may represent an important explanation for not only the lower protective effect of colonoscopy for right-sided colorectal cancer, but also the significant incidence of interval cancer. In addition, SSA/Ps are incompletely resected in up to 1/3 of cases. SSA/Ps also may be responsible for interval cancers more commonly because they are the precursor lesions for rapidly developing carcinoma via the microsatellite instability and CpG island methylator phenotype CIMP pathways. Both of these pathways have shown to be highly prevalent in interval CRC. Overall, SSA/Ps may be responsible for up to 30% of all colorectal cancers. Given their appearance, SSA/Ps can be difficult to detect and to differentiate from non-neoplastic mucosa on white light endoscopy, WLE. The detection rate for SSA/Ps varies significantly among endoscopy centers, ranging from 0% to 13.1%. Moreover, improper characterization of diminutive SSA/Ps could have significant consequences if resect-and-discard or diagnose and leave in situ strategies are implemented. An endoscopic misdiagnosis of one of these lesions as hyperplastic would not only potentially leave a premalignant lesion in situ, but even if the lesion was resected and discarded, it would falsely extend a patient's colonoscopy surveillance interval, leaving them at higher risk for interval cancer. The inability to distinguish SSA/P from non-neoplastic tissue and to clearly delineate borders of the lesion could also lead to incomplete resection. Dye-based chromoendoscopy showed promise with regard to improved detection and characterization of SSA/Ps, but the technique remains cumbersome and operator-dependent. Image-enhanced endoscopy, IEE modalities include virtual chromoendoscopy techniques such as narrowband imaging, NBI, eye-scan, autofluorescence imaging, AFI, and flexible spectral imaging color enhancement, FICE, as well as optical biopsy modalities such as confocal laser endomicroscopy, CLE, and high-resolution microendoscopy, HRME. IEE has been found to be relatively accurate in differentiating adenomas from hyperplastic polyps, but the ability of IEE to detect SSA/Ps and differentiate SSA/Ps from non-neoplastic mucosa is uncertain. The aim of this systematic review and meta-analysis was to evaluate the utility of IEE in the detection and diagnosis of SSA/Ps, with determination of the sensitivity and specificity of IEE in the differentiation of SSA/Ps from non-SSA/Ps and from non-neoplastic polyps. The author's primary hypothesis was that certain IEE modalities would have an acceptable sensitivity, greater than or equal to 90%, for the diagnosis of SSA/P, while the secondary hypothesis was that certain IEE modalities would be more sensitive in the diagnosis of SSA/P compared with WLE. Background and study aims: distinguishing sessile serrated adenomas/polyps, SSA/Ps, from non-neoplastic tissue may be challenging when white light endoscopy, WLE, is used. Image-enhanced endoscopy, IEE, has shown accuracy in differentiating adenomas from hyperplastic polyps. The aim of this systematic review and meta-analysis was to evaluate the utility of IEE in diagnosis of SSA/Ps. Methods: studies were eligible if they included patients undergoing colonoscopy with an endoscopy-based image enhancement modality. Endoscopic diagnoses, including SSA/P, were based on the appearance of polyps at IEE, and the corresponding histologic diagnoses of polyps were provided. The primary outcome was sensitivity of IEE for SSA/Ps differentiated from non-neoplastic lesions, primary convention, and differentiated from all non-SSA/P lesions, including adenomas, secondary convention. Results: 13 studies met inclusion criteria. Sensitivity ranged from 38% to 100%, but sensitivity greater than or equal to 90% was seen in 4 of 10 narrowband imaging (NBI) or magnification NBI studies. Pooled sensitivities for discriminating SSA/Ps from non-neoplastic lesions were 80% for magnification NBI, 60% for NBI, 49% for autofluorescence, and 47% for flexible spectral imaging color enhancement. In head-to-head comparisons with WLE, NBI 89% versus 75%, and magnification NBI 78% versus 63% demonstrated significantly greater sensitivity, while autofluorescence imaging 56% versus 66%, flexible spectral imaging color enhancement 100% versus 100%, and high-resolution endomicroscopy 88% versus 100% did not. Conclusion: IEE currently cannot be recommended as a diagnostic tool for SSA/P. While NBI studies showed promise, more IEE studies employing validated SSA/P criteria in well-defined polyp populations are needed. IEE studies assessing SSA/P detection rates at colonoscopy are also needed.